and welcome to Neurology Journal Club. My name is Ann Ye. I'm a professor of pediatrics and neurology at the Hospital for Sick Children at the University of Toronto and the director of the Pediatric MS and Neuroinflammatory Disorders program.
Hi, and I'm Daniela Castillo. I'm a child neurologist. I'm also a clinical fellow in the Neuroinflammatory Disorders program at the Hospital for Sick Children.
Today, we're going to be talking to you about a recently published article called Differentiating Multiple Sclerosis from Aquaporin-4 Neuromyelitis Optica Spectrum Disorder and MOG-Antibody Disease with Imaging. But first, we want to talk to you a little bit about some of the background that made this paper interesting to us. Now, as you all may recall from your medical school days, if you're as old as I am, you may recall that MS was one entity, and there were all kinds of variations of MS, some of which were considered more severe and devastating than others. And that was true until the mid-2000s, when a revolutionary change came about and the Aquaporin-4 antibody was discovered. At that point, it was clear that MS was not one thing, but there were multiple different entities that fell under the umbrella of neuroinflammatory disorders, of which MS was one, Aquaporin-4 related disease was some, and then some 10 years later, MOG antibodies came to the forefront and were described as being relevant to things that looked like MS, but were a little bit different. Right here, I have a few MRI scans that demonstrate typical features that might be seen at the acute phase with MS, Aquaporin-4 related disease, and MOG related disease, and which we all know about: MS with the periventricular lesions, the multiple spinal cord lesions, which are hemi lesions, and the fluffy abnormalities on MR. In Aquaporin-4 disease, we all remember that the longitudinally extensive lesion is the classical finding in Aquaporin-4 disease, with brainstem lesions and optic nerve lesions also being part of that classical picture. And then finally, with MOG-related disease, what we've learned over the last decade or so is that a severe optic neuropathy with a swollen optic nerve and multifocal brain lesions are typical in the acute phase. But what happens in the chronic phase? Well, we all know as well that with some of these disorders, these highly inflammatory disorders, the lesions may go away, and we may have a patient that comes into clinic with a previous event, and this has happened to me many times in my clinical practice, with a previous event, who were maybe traveling at the time or might be seen in a remote community with an event that occurred at some point, 6 months, 8 months before seeing me, who comes in and in whom I get a new MRI scan. And what I see is something very vastly different from the original MRI scan. And we all know that if treated aggressively, Aquaporin-4 disease, the spinal cord lesions seem to go away and the brain lesions seem to go away. And in MOG-related disease, the optic nerve may show marked atrophy, and infrequently the brain lesions go away. But are there differentiating features in the chronic phase in comparison to MS? How do we know when a patient comes into clinic whether we can say with high confidence there is a diagnosis of MS versus Aquaporin-4 related disease versus MOG disease? And are there structural metrics that can help us to understand that, such as using optical coherence tomography, which is a modality which has come to widespread usage within the MS and demyelinating disorders community, that can identify the retinal nerve fiber layer as well as the ganglion cell interplexiform layer, and many studies have shown is very good for identifying abnormalities that associate with these disorders. What are the structural metrics that rise to the top with brain, spine, and eye imaging? This is what the authors set out to look at in this study. Daniela is going to talk a little bit about the methods.
Yes. So the methods that were included in the study includes, first of all, the participants. So the authors included 91 individuals. Out of these 91 individuals, a third of them had relapsing remitting MS, another third of them had AAQP4 positive NMOSD, and the other third had MOGAD. And there was also another group of 34 individuals who were healthy controls. Now, in the MOGAD group, we know that 67% of them had a relapsing disease course, and the rest of them, which is about a third of them, had a monophasic disease. For the MS and the AAQP4 positive group, the diagnosis was based on validated criteria. So in the MOGAD group, the diagnosis was made based on the positivity of the MOG-Antibody testing based on a cell-based assay, when these individuals presented with an acutely validated event, which had some characteristics resembling a MOGAD phenotype. It's important to mention that within the exclusion criteria, all the individuals that had a relapse 6 months prior to the acquisition of the data were excluded from the study. So we have to keep in mind that the results that we're seeing are based on a chronic disease course and not the acute event. So when we move forward to the assessments that they made, they analyzed different clinical variables, but that was not the main focus of the study. So I'm not going to go into detail with that, but they were more focused on the structural metrics, as you mentioned, Dr. Ye. So one of them was the OCT, where they analyzed the retinal nerve fiber layer thickness and the ganglion cell inner plexiform layer thickness. But we have to also keep in mind that not every patient underwent this study, and this is something that we're going to discuss a little bit later when we talk about limitations. Another important focus was the MRI metrics or MRI markers, where they analyzed brain and spine volumetrics, which included gray matter, white matter, number of lesions, the central vein sign, and also the magnetization transfer ratio in the optic nerve. We know that the central vein sign is this central vein that we can see in white matter lesions when we use some specific iron-sensitive MRI sequences. And we know from recent work in the adult population is that it's showing some utility in differentiating MS from other neurological disorders. And we know from the MTR, or magnetization transfer ratio, that it could give us an estimation of tissue damage. So when we look at the analysis that the authors made using all these metrics or data, they divided into two parts. One was to trying to differentiate disorders based on the collected metrics, basically differentiating brain and MRI imaging metrics and OCT, optic nerve imaging metrics. And the other, or the second part, was trying to identify imaging markers that could differentiate these diseases. We have to keep in mind, though, that when they analyzed the optic nerve measures, they did an average of the two eyes, and they were not analyzed individually.
Yeah, that's really important to remember, Danny. So we're going to talk a little bit about the results of this study as the authors presented it, starting with the descriptives and then moving on to the comparisons the authors made. First of all, as far as the descriptives are concerned, the authors showed what many others have shown in other papers, and that is that there are more white matter lesions in MS than in MOG and AAQP4 related disease. But it was surprising to me, actually, to see that there were so many AAQP4 patients that had white matter lesions. So 100% of MS patients, as expected, had white matter lesions. 83% of AAQP4 patients had white matter lesions, and only 27% of MOG patients had white matter lesions. So big difference in those numbers. The other thing that the authors demonstrated in their descriptives was that only a small portion of AAQP4 and MOG-related patients had cortical lesions, 3 and 4%, whereas 73% of MS patients had cortical lesions. Again, another differentiating factor just from looking at the descriptives. And finally, and interestingly, cord lesions were an interesting discriminator in that 55% of MS patients, 40% of AAQP4 patients, and only 4% of MOG patients had cord lesions. Now, with regards to the eye metrics, and that's the OCT measures, I want to remind everyone that only about half of the patients actually got OCTs in the aquaporin-4 group, and about 2/3 of the patients got OCTs in the MOG-related group. Most of the patients in the MS group had OCTs. And within that, the retinal nerve fiber layer thickness group was larger than the GCIPL group. So keep that in mind when throughout this. But the authors demonstrated, as has been shown in other publications, that that MS compared to MOG showed differences in the retinal nerve fiber layer thickness, with MOG being lower in retinal nerve fiber layer thickness than MS, and aquaporin-4 versus MS showed a lower GCIPL, or ganglion cell interplexiform layer, in the aquaporin-4 group than in comparison to the MS. Again, not really surprising. And then the MTR was interesting as well, or showed differences where the MOG-related group had lower MTR than the MS group. But it's the comparisons that are actually really interesting, and Danny's going to talk about those now.
So as you mentioned, Dr. Ye, this is a big part of the analysis that was made in the study. So they tried to differentiate MS from AAQP4-NMOSD and also MS from MOGAD. So in the first, this table number 3 that we're seeing now, we can see that the most accurate individual MRI measure that could differentiate MS from AAQP4-NMOSD was the proportion of lesions with a central vein sign, and this had a 91% of accuracy. There were other individual measures such as the cortical lesions, number of white matter lesions, deep gray matter brain parenchymal fraction, and also the MTR of the optic nerve that showed a pretty good accuracy level in differentiating these diseases too. But what it's really interesting is that when they did a combination of some of these individual measures, the accuracy was even better. And in this case, when you consider the percentage of lesions with central vein sign with the number of cortical lesions and the MTR of the whole optic nerve, the accuracy was 95%, which is better than any individual measure that I just mentioned before. So if we move forward and compare now, or try to differentiate MS from MOGAD, we can see there are some differences in the individual measures that show the highest accuracy. So in this case, the number of white matter lesions show the highest accuracy with a 94%. And then we can remember that from our study population in these studies that 27% of MOGAD patients had white matter lesions, and 100% of MS patients had white matter lesions. So there's a clearly differentiating point in these two diseases regarding to the number of white matter lesions. And similar findings when we look at the cortical lesions. We know in the MOGAD group, only 3% had cortical lesions, which is again a clear differentiating point from MS, which they had 73% of them had cortical lesions. Another thing interesting in these results is that RNFL was also showed a good accuracy in differentiated MS from MOGAD, and this was not seen when MS was differentiated. We were trying to differentiate with AQP4. In this case, any combination of measures, such as cortical lesions added to RNFL, did not show a better accuracy than an individual measure, which in this case was the number of white matter lesions. So that was the best one with 94% of accuracy, which I found very interesting too.
Yeah, really interesting, Danny. And if you look at this this last table, it's actually quite interesting because the accuracy of number of cortical lesions is 84%. And you might ask yourself the question, can you gain any more? And this is what the authors asked themselves. Can you gain any more by adding anything? So they added RNFL to it. And in fact, the accuracy is the same. So it seems to me that the bottom line for MOG, chronic MOG, is if you see a paucity of white matter lesions and no cortical lesions or almost no cortical lesions, and you're wondering, is this MS or is this MOG? Then you may want to push yourself in the MOG camp for that. And thinking about that last slide about aquaporin 4 versus MS, what I found really interesting was that the central vein sign differentiated the MS from the aquaporin 4, but it didn't differentiate the MS from the MOG-related disorders. And although we didn't talk about this, the authors have this this very interesting chart that suggests that, in fact, the central vein sign in those MOG patients with white matter lesions, the central vein sign is just as common as in MS patients, or was almost as common as in MS patients. So for aquaporin 4, it seems like the bottom line there is looking at those cortical lesions to make sure that there are almost no cortical lesions, and looking at the central vein sign to see if you can see the central vein sign. And if the central vein sign is present, then you're more likely than not going to be pushing yourself towards an MS diagnosis. I think these are all really great lessons from the article. But, you know, I was a little bit surprised and maybe a little bit disappointed that the eye metrics from the OCT didn't rise a little bit higher to the top than what these authors found. And I wondered, as you know, we discussed earlier, I wondered if this might be related to selection bias with the patients, in that only about half of the aquaporin 4 related patients got OCTs, and about 2/3 of the MOG related patients got OCTs. So I wonder if all of those patients had gotten OCTs, whether some of the metrics, RNFL, GCIPL, might have risen to the top or been comparable to some of the other metrics.
Yes, I totally agree. And I was also thinking that the sample population was not a very large one. So because we have 30 patients in each group, so it might not be completely representative of the disease in these cases. And if we look at the MOGAD group in particular, we know 1/3 of them had a monophasic course. But then if we look specifically for when the antibody testing was done for these patients, in most of the cases, about 2/3 of them, the antibody was tested in the acute phase, and only about 1/3 of them had later testing, which was probably, we can guess because it's not very clear, that might have happened when they had a relapse. So for me, there are no clear parameters when to define specifically how the diagnosis of a relapsing course was made, which I think it would have been useful to know too when we interpret these results.
Yeah, I think in particular from a clinical sense, when you're thinking, should I treat or should I not? And are there typical features of individuals with relapsing disease? I wonder if it might be useful to look at those 2/3 of patients and say, are they different from the 1/3 that are non-relapsing? Because as a clinician, what I'd like to know is, if I look at this MRI, can I predict whether or not this person is going to have a relapsing course, so I can prevent further injury? So I think that's a really good point. You know, I do think that this paper provided me with a lot of clinical insights about what I, might think about when I look at the next patient who comes in after the acute event, where I'm trying to decide, is this aquaporin 4, is this MS, or is this MOG? Because in my setting and our setting, it takes a couple of weeks to get the antibody testing back. So it's helpful in being able to talk to families for sure. So I think this paper has provided some interesting insights. I do think there are a few things that we look forward to in the future from this kind of work, and that's having larger collections of patients, so that we can really understand, is this representative or is this not representative of the typical MS, MOG, and aquaporin 4 patient? Because I was a little surprised about the number of white matter lesions in the aquaporin 4 patients, for example, and the central vein sign question still is boiling in my head. And actually, I think it would be important to look to see if these findings hold out when you have every patient receiving OCT, whether any of those optic nerve metrics actually rise to the top.
Yes.
Yeah, so anyway, I really enjoyed this paper, and thank you so much for the conversation.
Thank you for having me.
Yeah, that was really
Yes.
great. Thank you all for joining us, and I hope you have a great day.